Welcome back to the deep dive. Today, we're tackling a really high-stakes concept, sensory perception.
hmm
Specifically, we're focusing on how we assess and manage eye and vision disorders. You know, vision is just so fundamental for independence, for safety.
Absolutely. And when it fails, the impact is,
Yeah,
well, it's huge and immediate.
exactly. So our mission today, especially for you, the learner, is to pull out the most critical clinical priorities. The real need-to-know stuff, the red flags, the actions, straight from the sources.
Right. We want to synthesize this pretty complex material into knowledge you can actually use.
Yeah.
It's not just about the anatomy, though. We'll touch on that.
Yeah.
It's really about understanding the two main ways things go wrong mechanically: failure of clarity,
Points towards cataracts.
right, and failure of pressure control.
Which is glaucoma territory.
Precisely. So we'll cover assessment basics, then dive into managing these,
Yeah.
always focusing on patient safety and what falls within the nursing scope.
Okay, so let's start with just the quick snapshot. What is a cataract again?
Simply put, it's opacity, a cloudiness that develops in the eye's lens. Think of it like trying to look through a foggy window. It distorts the image coming through.
Gradually gets worse.
Typically, yes. Now, glaucoma, that's different. It's more insidious in some ways.
How so?
It's a group of disorders, but the common factor is increased intraocular pressure IOP. If that pressure stays high and isn't treated, it basically squeezes the life out of the retina and optic nerve fibers, cuts off their oxygen.
And that damage is permanent.
Permanent, irreversible vision loss.
Yeah.
That's why catching it is so critical.
Okay, so to really get why pressure or clarity loss is so bad, we need a quick refresher on the mechanics. Light comes in
Through the cornea, then the lens.
and lands on the retina at the back, right? That innermost layer.
Exactly. The retina is like the film in a camera. It's packed with photoreceptors. You've got rods
For dim light, peripheral vision.
and cones, which handle bright light, color, and all that sharp central detail.
Got it. So what keeps that whole system working pressure-wise?
It boils down to a really delicate fluid balance. That's where IOP comes in. There's this fluid aqueous humor.
Okay.
It's constantly being made by a structure called the ciliary body, and crucially, it has to drain out at the same rate.
Through the canal of Schlemm. Am I remembering that right?
You got it. Canal of Schlemm. Now, if that drainage system gets blocked or slows down,
Pressure builds up inside the eye.
bingo, IOP rises. And here's the key clinical takeaway. The Y-high IOP is an emergency. That pressure physically compresses the tiny blood vessels feeding the retina and optic nerve,
Which cuts off the oxygen supply.
leading to hypoxia, localized hypoxia, and those nerve cells start to die quickly.
Okay, so it's all about that balance. What about just getting older? Do things naturally change?
Oh, absolutely. Aging affects the eye structurally and functionally. You see the lens start to yellow and harden a bit.
Which leads to presbyopia, right? That needing reading glasses thing.
Exactly. Difficulty focusing up close. That's a functional change. Structurally, you might see decreased muscle tone around the eye, maybe increasing the risk for ectropion, where the eyelid turns outward.
What about that white ring you sometimes see on older people's corneas, arcus senilis?
Good point. Arcus senilis, that's those fatty deposits around the edge of the cornea.
Yeah.
It looks noticeable, but the key thing our sources stress is that it's benign. It does not affect vision itself,
So functionally, the lens hardening and yellowing are bigger deals clinically.
for sure. And just the increased risk over time for the big ones: cataracts and glaucoma.
Which brings us straight to health promotion. The sources really seem to emphasize protecting the eyes and linking systemic health.
They really did. It's crucial teaching. Simple stuff first. Wear UV filtering sunglasses. Cuts down the risk for both cataracts and even melanoma of the eye.
And protective eyewear for risky activities, sports, workshops.
Absolutely. But the systemic link is huge. If you have diabetes or hypertension, managing those conditions aggressively isn't just for your heart or kidneys.
It's protecting your eyes, too.
Directly. Those conditions wreak havoc on the tiny blood vessels in the eye. So tight control and annual eye exams are non-negotiable.
Okay, let's shift to assessment. What are those absolute stop everything and call the provider red flags?
Right, the immediate emergency cues.
Yeah.
If a patient reports sudden vision loss or even persistent loss that started within the last, say, 48 hours,
Okay.
or any kind of eye trauma, seeing a foreign body in the eye, or sudden really bad eye pain,
That's a call right away.
immediately you notify the eye care provider. Time is vision in those situations. Delay can mean permanent damage.
Beyond those emergencies, what specific things are we looking for during a routine assessment?
We're looking at the eyes themselves. Are they symmetrical? Is one sunken in that's in ophthalmos, or bulging out exophthalmos.
Like you might see with thyroid issues.
Exactly. Then pupils, critically important. We check pearl A pupils equal, round, reactive to light and accommodation.
And we look for differences in size between the pupils.
Yes, that's anisocoria. But remember, about 20% of people normally have slightly unequal pupils. So inequality itself isn't always alarming.
It's the reaction to light that's key, the direct and consensual response.
That's the crucial part. Both pupils should constrict briskly and equally when you shine a light in one eye.
And going back to the pressure issue, how do we actually measure IOP?
That's done using tonometry. It's the standard tool. Normal IOP is generally considered to be between 10 and 20 millimeters of mercury.
HG.
Right. And because glaucoma risk goes up with age, the recommendation is for all adults over 40 to get screened with tonometry.
Okay. One more critical safety point from the diagnostic section.
Yes, the MRI contraindication. This is vital. If there's any suspicion that a patient might have a metal foreign body lodged in their eye, maybe from grinding metal or an injury,
MRI is out.
absolutely contraindicated. The powerful magnet in the MRI machine could literally pull that metal fragment through the eye structures. Catastrophic internal damage. Always screen for that history.
Okay, let's pivot to the most common reason for that foggy window vision. Cataracts. What's actually happening inside the lens?
Well, the lens is mostly made of water and specific proteins, arranged very precisely for clarity. With age, it tends to lose some water, and the protein fibers become denser, they clump together.
They lose that nice, clear arrangement.
Exactly. They become opaque. Light can't pass through cleanly, so the image gets distorted. Besides age, things like heavy UV light exposure over years, direct eye injuries, smoking.
And those systemic diseases again?
Yes, diabetes and hypertension are big risk factors. The sources mention Table 42.4, which lists several causes, but age is by far the most common.
How does it usually start for the patient? What do they notice first?
It's often very subtle, maybe slightly blurred vision or colors seem a bit faded, less vibrant. Then it progresses. Trouble seeing clearly at night is a big one.
Especially with driving, glare from headlights.
Classic symptom. Increased glare sensitivity. Blurred vision, sometimes even double vision in one eye. But here's a key differentiator from something like acute glaucoma.
What's that?
With typical age-related cataracts, there's usually no pain and no eye redness. That's important.
So, if someone has sudden pain or redness, we're thinking something else.
Definitely something else, likely more acute. Diagnostically, the provider uses an ophthalmoscope. They'll actually see the cloudy densities in the lens.
And as it gets worse.
As the cataract matures, that red reflex you normally see when shining light on the retina, it might become dim or completely disappear. The pupil itself can even start to look kind of bluish-white.
Since you can't really unclump those proteins, surgery is the only fix, right?
That's right. Surgery is the only cure. It's usually done when the vision loss starts significantly impacting the person's daily life, reading, driving, cooking, etc.
And the standard procedure is?
It's called phacoemulsification. Basically, they use a small probe that emits ultrasound waves.
Like sound waves.
Yeah, high-frequency sound waves break up the cloudy lens into tiny pieces. Then those pieces are gently suctioned out.
And they put something in its place.
Yes. An artificial intraocular lens, an IOL, is implanted right where the natural lens was. Restores focus.
Okay, surgery's done. Now comes the really crucial nursing part, postoperative care and safety teaching. This sounds like where things can go wrong if instructions aren't followed.
Absolutely critical.
Yeah.
It all centers around one main goal: preventing any sudden increase in that intraocular pressure.
Because the eye just had surgery, it's vulnerable.
Exactly. You don't want anything stressing the incision site, popping a stitch, causing bleeding inside the eye. So the list of don'ts is vital. You need to know these. They're often listed in tables like 42.5 in the text.
What's on the list?
Avoid anything that mimics straining, like the Valsalva maneuver. So no bending over at the waist.
Lift with the knees.
Right. No lifting anything heavy. Typically the cutoff is around 10 pounds.
Okay.
Absolutely no forceful sneezing or coughing if possible. Try to sneeze with your mouth open. No straining during bowel movements.
So stool softeners might be important.
Very important. And antiemetics if they feel nauseous, because vomiting also spikes IOP. Basically, keep activities gentle.
And what warning signs do they need to report immediately after surgery?
Okay, some mild itching is normal, maybe a bit of a gritty feeling. That's expected. But what they must report right away is any decrease or reduction in vision compared to how it was right after surgery.
So if vision gets worse instead of better.
Yes. Also, sharp, sudden pain. A little aching is okay, but sharp pain is a red flag. And any discharge that looked like pus yellow or green that signals infection,
Infection is a big risk.
huge risk. And finally, we have to stress how important the eye drop schedule is. It's often multiple types of drops, antibiotics, steroids, anti-inflammatories, several times a day for maybe weeks. Adherence is key to prevent infection and inflammation.
All right, let's switch gears back to the pressure problem, glaucoma. We know it causes permanent vision loss, usually starting in the periphery, but there are different types, right?
Yes, and it's really important to distinguish between the main two. The most common type by far is POAG.
Primary open-angle glaucoma.
Right. Think of this as the silent thief of sight. Why? Because the onset is incredibly slow and gradual. The drainage channels, the trabecular meshwork, they just become less efficient over time. Outflow reduces slowly.
So the pressure creeps up gradually.
Exactly. IOP might be in the, say, 22 to 32 millimeter Hg range, higher than normal, but not dramatically so initially. And because it's slow, it's usually asymptomatic in the early stages. Patients don't notice the peripheral vision loss until it's quite significant.
Scary. So what's the other main type, the one that's an emergency?
That's PACG, or primary angle closure glaucoma. This is the complete opposite. It's sudden, it's dramatic, and it's often very painful.
What happens in angle closure?
The iris, the colored part of the eye, actually bows forward or gets displaced, and it physically blocks the angle where the aqueous humor drains out.
So the drain is suddenly plugged completely.
Completely plugged. Outflow stops abruptly. IOP skyrockets, often 30 millimeter Hg, or even much higher, 50 plus sometimes.
Wow. And the symptoms reflect that?
Absolutely. Sudden, severe eye pain, headache, nausea, vomiting, seeing halos around lights, sudden blurred vision, and the eye often looks red. It's a true ocular emergency. Needs immediate treatment to lower the pressure and save the optic nerve.
Okay, so two very different presentations. Since glaucoma damage is permanent, there's no cure, right? Treatment is about managing it.
Exactly. The goal is damage control, lifelong management. We want to maintain the best possible remaining vision by keeping that IOP consistently low.
And that's primarily done with medication?
Primarily, yes. Lifelong eye drop therapy is the cornerstone. These drugs work in basically two ways. Either they decrease the amount of aqueous humor being produced,
Turn down the faucet.
or they increase how well it drains out. Open up the drain a bit more.
And the nursing priority here isn't just giving the drops, but making sure the patient understands why and takes them consistently.
Absolutely. This is critical teaching. These drops don't fix the damage that's already done. They only prevent further vision loss. So, missing doses means the pressure can creep up again, causing more irreversible damage. Lifelong adherence is paramount.
And there's a specific technique we need to teach for administering most of these drops. Something about systemic absorption.
Yes, this is a huge safety point, a drug alert in the text. Many glaucoma eye drops can be absorbed through the nasal mucosa via the tear duct and get into the bloodstream.
And cause systemic side effects.
Yes, things like bradycardia, low blood pressure, sometimes even asthma exacerbation depending on the drug class, like beta blockers. So we teach punctal occlusion.
How does that work?
After putting the drop in the eye, the patient needs to gently press a finger against the inner corner of the eye, right near the nose where the tear duct opening is.
Hold it there for a bit.
Hold that gentle pressure for about a minute, maybe two. This physically blocks the drop from draining into the tear duct and getting into systemic circulation. It keeps the medicine in the eye where it's needed.
Simple technique, big impact.
Very big. Reduces systemic side effects significantly.
What if drugs aren't enough? Are there surgical options?
Yes, if drugs don't control the IOP adequately, surgery might be needed. Things like laser trabeculoplasty, which tries to open up the drainage channels, or a trabeculectomy, which creates a new drainage pathway.
And finally, we can't forget the person dealing with this diagnosis. Gradual vision loss, the fear. It must take a toll.
Immense toll, especially with POA. The slow, creeping nature of the vision loss can cause significant anxiety, depression, fear of losing independence. With PAPCHIL, it's the trauma of the acute event.
So psychosocial support is key.
Non-negotiable. We need to assess their coping, provide support, and make referrals maybe to mental health professionals, low vision specialists, or support groups where they can connect with others going through the same thing.
Okay, let's quickly cover a few other conditions that pose serious threats, starting with the cornea, the clear front window of the eye.
Right. What happens if that gets scratched? A corneal abrasion. An abrasion is a scratch, and an ulceration is an open sore. Both are emergencies, mainly because the cornea doesn't have its own direct blood supply to fight infection.
So infections can take hold really fast.
Extremely fast, and can lead to scarring, permanently affecting clarity. That's why if an infection is suspected, Anti-infective eye drops, antibiotics, antifungals need to be started immediately,
Right.
often broad spectrum at first, even before they know the exact bug causing it.
Don't wait for the culture results.
Don't wait. Time is cornea. If the damage is too severe, sometimes a corneal transplant, a keratoplasty, is needed.
Replacing the diseased cornea with donor tissue. What's the key post-op teaching there?
Similar IOP precautions as cataract surgery, plus a few specifics. Patients often need to lie on their non-operative side to reduce pressure on the graft. They'll wear an eye shield, especially at night. And crucially, they need to know the signs of graft rejection.
What should they look for?
The mnemonic, often used, is RSVP: redness, swelling, vision decrease, pain. Also, any inflammation seen near the edge of the graft or increasing cloudiness of the cornea itself. Report immediately.
Okay, moving deeper into the eye, the retina. What about macular degeneration, AMD?
Huge issue. AMD is the leading cause of severe vision loss, even blindness, in people over 65. It affects the macula, the central part of the retina responsible for sharp detail vision.
There are two types, right? Dry and wet.
Correct. Dry AMD is much more common, maybe 80–90% of cases. It's a slower process involving the breakdown of light-sensitive cells and accumulation of deposits called drusen. Causes gradual central vision loss.
And wet AMD?
Wet AMD is less common but more severe and progresses faster. Abnormal blood vessels grow under the retina, leak fluid and blood, and cause rapid damage to the macula. Significant central vision loss can happen quickly.
How's AMD managed?
For dry AMD, it's mostly about slowing progression. Things like specific vitamin formulations, often containing lutein and zeaxanthin, are recommended based on large studies. Plus, maximizing the use of remaining peripheral vision with low vision aids. Wet AMD has treatments like injections into the eye to stop vessel growth.
Okay, now for perhaps the most dramatic retinal issue, detachment.
Retinal detachment. Yeah, this is when the retina physically pulls away from the underlying tissue, the choroid, which supplies its oxygen and nutrients.
What does the patient experience? How does it present?
It's usually sudden, and surprisingly, it's typically painless. That's key.
Painless. Okay.
Yeah, the classic signs are seeing sudden bright flashes of light that's called photopsia, or a sudden shower of new floaters like spots or lines drifting in their vision, or the most classic description, feeling like a curtain or veil is being pulled over part of their visual field.
That sounds terrifying. Is it an emergency?
Absolute emergency. Needs immediate evaluation and surgical repair to reattach the retina, often with a procedure called a scleral buckle, or sometimes internal methods using gas or oil bubbles.
What's the post-op care like for that?
Very specific. If a gas or oil bubble was used inside the eye to hold the retina in place, the patient might have to maintain a very specific head position, like face down, for days, even weeks, to keep the bubble pressing on the right spot.
Wow, that must be difficult.
Extremely challenging. And they also need to avoid activities involving rapid eye movements, like reading or writing, usually for the first week or so, to let the retina heal without being disturbed.
Okay, let's wrap this section with eye trauma. We talked about chemical splashes needing irrigation.
Right. Immediate copious irrigation with normal saline, usually for at least 15–20 minutes. You check the pH of the eye before and after, aiming for neutral. Always irrigate from the inner corner towards the outer corner to avoid washing contaminants into the other eye.
But what about when something actually penetrates the eye? An object sticking out?
This is the absolute #1 do not touch rule in eye trauma. You walk in, you see an object, a piece of metal, a stick, whatever, protruding from the eyeball. Your instinct might be to pull it out.
Don't do it.
Never. Absolutely never attempt to remove a penetrating object yourself. Only an eye care specialist should do that. Why? Because pulling it out could cause the internal structures of the eye, the iris, the lens, even the retina, to prolapse out through the wound.
Catastrophic.
Certainly catastrophic. It guarantees severe vision loss and might even necessitate enucleation.
Surgical removal of the entire eyeball.
Exactly. So if you see a penetrating object, stabilize it if possible without putting pressure on the globe, shield the eye, often with a paper cup taped over it, not pressing on the object. Shield the other eye too to reduce movement, keep the patient calm and still, and get them to specialized care immediately. Do not touch the object. #tag outro.
Okay, wow, that was a lot of critical information.
Yeah.
Let's try to unpack this and pull out the absolute essentials for the learner.
Yeah, let's distill it. We looked at how vision works, focusing on that delicate IOP balance.
Right, and the huge difference between the slow, sneaky progression of primary open-angle glaucoma
Versus the sudden painful emergency of primary angle closure glaucoma. Knowing the difference in presentation is key.
Definitely. And then the safety measures that just kept coming up after any kind of eye surgery, especially cataracts or retinal work.
It's all about preventing increased IOP. That list of restrictions, no bending, lifting, straining, is non-negotiable patient teaching, referenced in Table 42.5.
Got it. And for trauma, the rule we just hammered home, see something sticking out of the eye.
Shield it. Stabilize if you can without pressure, but never ever pull it out. Protect what's left.
Okay. Final thought for our listeners today, something to really stick with them.
I think it's realizing where the nurse's power truly lies in managing these chronic or post-surgical conditions. Think about glaucoma. The medicine works, but only if the patient takes it. Lifelong adherence, taught and reinforced by the nurse, is literally the difference between sight and blindness for that person.
And after surgery.
Same thing. The surgeon does their part, but success often hinges entirely on the patient meticulously following those post-op instructions, especially the IOP precautions. The nurse's teaching, their reinforcement, their assessment of understanding, that is the intervention that often preserves vision. It's not passive. It's active protection through education.
A powerful reminder that our teaching is a critical clinical intervention.
Fantastic. Well, thank you for joining us for this essential deep dive into eye and vision care.